Hello, my name is Dr. Alon Melnick, and it's my pleasure to welcome you to this session titled A Focused Schizophrenia Update, Emerging Pharmacological Solutions for Management of Metabolic Disruptions. This activity is supported through an independent educational grant from Alkermes Incorporated. While I introduce the speakers for this session, if you haven't already done so, please take a moment to answer the polling questions. You should see them on your screen depending on the device you're using, either on the right of the live stream or below the live stream. These questions will be asked again at the end of the program, and we really appreciate you answering the polling questions. It is my pleasure to introduce two of our two speakers for this session, Dr. Jacob Balin and Carmen Kosicek. Dr. Balin is a clinical professor, co-director of Inspire Clinic, the medical director for H2 Inpatient Psychiatry, Department of Psychiatry, Stanford University. Ms. Kosicek is CEO, founder, and provider of Ally Psychiatry. You can type in your questions for the presenters in the question and answer box to the right of your screen, as well as upvote questions submitted by other attendees if you want to see their questions answered. We'll try to answer all the most popular questions at the time remaining at the end. Without any further delay, let's begin the session.
Thank you, Psych Congress Elevate members, for coming to our presentation today to learn about a schizophrenic update for schizophrenia. Dr. Jacob Balin will be joining me, and my name is Carmen Kosicek. I'm a psychiatric mental health nurse practitioner. We do have faculty disclosures that are here for your review, as well as the general disclosures for the program. Learning objectives, as you can see, because you will have a copy of all these slides for you on Elevate, so don't worry, sit back, learn, and take some notes. But let's go over, starting with the state of schizophrenia with the treatment options that are available to you right now today. So as a brief overview, we all remember from school as well as continuing education that schizophrenia generally affects a small amount of the percentage of population, with about 3.5 million people in the United States. However, schizophrenia still is one of the largest consumers of healthcare dollar spend, to the tune of, for these 3.5 million people, 155 billion with a B dollars. One of the biggest problems with this medication class, the antipsychotics, is negative weight gain, negative metabolics, increase of cholesterol, increase of prolactin. All of that contributes to non-adherence. Tough one, tough one. So what happens? How much of the time does this happen? Well, this is a meta-analysis of data, and you will see in the meta-analysis of data for weight gain issues, you're talking more than 10,000 patients. The overall sample size in the meta-analysis was 17,000 patients. Glucose, cholesterol, triglycerides, all of these really had large numbers of people, patients, in the sample size, showcasing that things were not okay with taking medications for schizophrenia due to the bad side effects of the medications. So let's look at an everyday real patient and his mom. You're going to see Jeremy, age 22, and I'll let the video do the talking. You can see here the med mix, and let's hear how this plays out.
He was away at college again after COVID, and well, we just thought that he'd gotten into the wrong crowd and that this was drug related, like something in his marijuana, a K2 exposure maybe. He was so paranoid, thinking that all the kids at the dorm were plotting against him, and then he was threatening to jump out of the windows on the 3rd floor of the dorm. We thought that perhaps it was from all the stress of COVID, the lockdowns and all, but really he just lost it. His buddies took him to the ER, and then he stayed in the hospital for 2 days. They discharged him on oral meds, but he's not that good at taking pills. Being gone at school and all, just all of that. And things were good for a few weeks, but now the paranoia is back. His uncle Juan, on his dad's side, he has schizophrenia. And now we know the truth, that he has schizophrenia too. But, it's just so hard to accept because he's so young. And I was just really wondering, is there any updated medications that can help him? Not ones that will, weigh him down and make him gain a lot of weight, and accidented, just the issues with all the meds and that. But I mean, it is 2021. I mean, there has to be some better options than what his uncle had, right?
Hey, did you hear what she said? Did you take notes? He's not good at taking pills. Most people aren't. So that will also have you add into the variables of what medication to pick, long half-life medications or different routes of administration. A few weeks he was good, then not so much. I wonder if he stopped taking his pills. Also, there was a family history of schizophrenia with his uncle, Juan, and the mom continues to plead that there have got to be newer, better medication options for Jeremy that don't lead to the side effects that have historically plagued this class. Let's take a peek and hear what Jeremy has to say.
I don't want to take something that will make me act medicated. I want to still be able to enjoy life, not gain a ton of weight, and not compromise my physical health for my mental health. Are there newer options for me to try? I mean, these pills they sent me home on. I Googled them. There is no way I'm taking them. What they would do to me? No. If there were pills that were better, I would take them. Even a few times a week.
Okay, what'd you hear? I heard that he's willing to try and is absolutely open-minded to taking medications for his schizophrenic diagnosis. I also heard that he already is saying it might not be every day. At least that's realistic. Most people don't take pills every day, even though we prescribe them that way. He's pointing out what he doesn't want, which is a hard hit on histamine or something that makes him feel tired, not a slam down on dopamine. So again, all these different things to think about when you're picking meds for your patients. So what do you have out there? And let's look at the adverse effects of the antipsychotics that you have. Again, look at what I just mentioned, dopamine, histamine. What else is out there? What else could happen of medications that you're selecting? You'll see on the slides, elevated prolactin. Elevated prolactin is another measure that should be looked at in the blood work that you're doing on patients. But why? Because elevated prolactin, as you may recall, decreases bone density. So you don't want to trade off physical health and mental health, just like he said. Look at weight. Look at the cognition. Is it dulling them? Is it turning that human down? Look at all the options that your patient wants to have addressed as a goal and what medications then you can reach for that can help. Studies have continued to demonstrate that if they're not taking medications, a lot of the times it's because of the side effects. And right here, it will show you over and over again that weight gain is a concern. Gynecomastia is a concern. EPS, these are all high points of concern. So read through this, go over the risks and benefits with your patient and reach for better medication options. Weight gain again and again and again continues to come up. Or like Jeremy said, he didn't want to feel sedated all the time, the somnolence. So take a peek at what fits your patient's goals and what medications you have available to you right now today. So again, this is a meta-analysis. What you should do is generally pick out your top few meds that you want to be able to pull from readily when you're prescribing and look them up and actually see what the FDA clinical trial showcased on adverse events of that particular product. Again, this is not a head-to-head, so you can't compare it that way, but it will absolutely help you hone down on what medications you might want to first reach for. For example, on another meta-analysis, sadly, what you're going to see, many of you, what you were taught in school or what you might be providing today are actually at the very bottom area of this slide. Why are you first choosing for meds in the bottom third? Why are you not being willing to fill out prior authorizations for meds that don't have these horrible side effects? You know the patients aren't taking them. So think about that and think about that wisely. So remember, weight gain is the most common and people tend to see it in their clothing. It's expensive to buy new clothes. So let's see what's happening with Jeremy. Remember, he was sent home on a medication, but he already admitted that he was intermittently taking it, and his mom noticed that with the side effects too, as well as the return of the symptoms.
I am so concerned about him all the time. Like, I'm always wondering, is he going to be okay? Is he not going to be okay? You know, it's just this hamster wheel that I can't get off of. And he just, I know he's not taking his meds all the time either.
I just don't want to take something that makes me so tired, so medicated. I can tell my jeans are tighter, so I wear basketball shorts all the time, which is okay. Summer is almost here.
Jeremy's telling you again and again, he's tired. Now his pants aren't fitting. It's not even summertime and he had to already switch over to basketball shorts. There's medications that you can use right now today that don't have all these side effects. Even more exciting is what's on the horizon. Dr. Jacob Ballin, could you please teach us?
Thanks, Carmen. That was really excellent. We're now going to switch over and talk a little bit about some of the current recommendations for things that you can do with your patients, as well as what's in the pipeline going forward. Currently, if you have a patient who's gained weight with antipsychotics, there are a number of things that you can do. You can start out with what you should probably be doing and probably already have been doing, which is to make lifestyle recommendations. We'll talk a little bit about that more in a minute. You can change the medication to a medication that is less risky for metabolic complications. You can consider augmenting with another agent. And lastly, which we won't get into in any more detail, is bariatric surgery, but that is an option for some patients. The current recommendations involve thinking about it through a three-step process. You want to think about this from the very beginning before you even prescribe the first medication. At initiation, you want to have already started talking with your patients about lifestyle interventions like managing their diet and including exercise as part of their treatment. As soon as you start to see that there might be some adverse events, that's when it's helpful to start talking even more about what are some more direct weight loss interventions you can take. And of course, if the weight gain becomes more significant, now you really need to make sure you're doing more than talking about the interventions, but really taking action. Let's start with what is right out there for everybody. Exercise. Exercise is important for a number of reasons. Exercise can help with cardiac capacity, it helps with cognition, it helps with a behavioral activation strategy. You want to be making sure that your recommendation fits with what a person can accomplish. And so we tend to recommend starting at 30 to 60 minutes, 3 to 7 days a week. More is better, but you don't want it to be so much that it becomes too hard for a person to manage. Intensity is important, but really something that is low and slow can also be very helpful for managing with weight. Have people think about things that they're willing to do, that they enjoy, and of course you have to take into consideration what sort of access and cost implications there might be for an exercise regimen. The next thing to consider is thinking about what is a lower risk antipsychotic. There really is no antipsychotic out on the market currently that is a neutral antipsychotic for weight. All of them carry some risk for some people. That being said, there are some that are less risky. We'll talk a little bit in more detail about lumateperone in a minute, but lorazepam, ziprasidone are out there, as well as some of the partial dopamine and serotonin agonists like cariprazine, aripiprazole, and brexpiprazole. It can be very effective from a metabolic perspective to switch, but you do want to always be making sure that you're balancing the psychiatric symptom coverage as well, and making sure that that is not something that is in jeopardy. One of the newest agents on the market is lumateperone. You may have missed it because it happened to be approved right as the pandemic was getting started, but it's an important new option to consider and has a lot of implications for both helping with the potential for helping with negative symptoms as well as for being metabolically friendly. It has a number of important and interesting affinities, which you can see here on this slide. One interesting study showed what happened when people were switched from an antipsychotic that they were currently taking to lumateperone for 6 weeks and then switched back to the antipsychotic they had been on before. It's interesting to see that a number of the different parameters really decreased. You can see that there was notable decrease, especially in triglycerides, which is a real harbinger for diabetes. And you can also see that while there was no change in glucose when on lumateperone, as soon as the switch was back to the standard of care, within 2 weeks, fasting glucose had elevated again. There are a number of other treatment options that you can consider as well that are already on the market, many of which are off-label. Metformin is available. That has a couple of studies that have showed some modest benefit. And for people who are at great risk for weight gain, it's probably worth considering adding metformin. Similarly, topiramate has been shown to, in some cases, help with weight loss. Topiramate does come with a risk of cognitive side effects, which often can be intolerable for people. But it does seem that it can be helpful for some people to lose weight, and that may be one option for folks. Lastly, there is a medication that is FDA approved for weight loss, the bupropion naltrexone combination, but hasn't really been studied sufficiently in schizophrenia to warrant any conclusions. There was one very small study that didn't show a difference, but really too small to draw a lasting conclusion. Some of the medications that have been getting some press, albeit again off-label, for weight loss have been the GLP-1 agonists. These are medications that are approved for type 2 diabetes. There's a number of them out there, and historically their use has been limited by the fact that they have all been subcutaneous administration. There was a study that was recently published in the New England Journal looking at people who were obese from all comers, but that showed a notable decrease in weight with semaglutide. Semaglutide is one of the medications that is available orally. It is again approved for type 2 diabetes and not for schizophrenia or antipsychotic induced weight gain, but is something that is becoming increasingly worthy of consideration. Key points. There are a number of things that you can do to help people that are already out there. Diet and exercise can be something that is very valuable. It can also be something that you can talk about and should be talking about at every visit. Similarly, there are medications that are higher risk for weight gain, as we've talked about before, and so switching to a lower risk medication may be worthwhile. Lastly, you can do things like augmentation, whether it's with metformin or a GLP-1 agonist potentially. And lastly, there's the consideration of bariatric surgery in the most severe cases. Switching now, let's talk about some of the medications that are in the pipeline, and then we'll talk about a brand new, recently FDA-approved medicine. In the beginning of the pipeline, there's currently in phase 2 clinical trials a drug called miricorilant. Miricorilant is an interesting medication. There isn't a lot of human data yet, but I'm showing here is a chart that shows how it was effective in rats. You can see that when miricorilant, which is a cortisol modulator, when it was given, there was a notable decrease in weight when taken alongside olanzapine. Miricorilant is interesting because it is similar to a medication that has been used for things like psychotic depression and also for abortion, but most notably, it has no progesterone activity and therefore is not of concern, and that has allowed for it to be tested more widely. There is currently a phase 2 trial of miricorilant ongoing. Similarly, and a little further along in development are the trace amine-associated receptor 1 agonists. There are two that are primarily leading the pack right now. There's the RO6889450 currently in phase 2, which is a partial agonist of these receptors, and SEP36386, which is a full agonist that also has some 5-HT1A agonism associated with it too. TAR1 receptors are interesting because they're located throughout the body. They're intracellular, and so they can be a little bit more difficult to appreciate as well. The fact that it is trace amines that are here means that it's very, very low concentrations of these amines that seem to carry notable effect. Looking at this figure, you can see a little bit about how the TAR1 mechanism works. Ultimately, it works a bit like a shock absorber to the dopamine and glutamate system. In a lot of the areas of the body where metabolic control occurs, namely in the liver, in the stomach, in the pancreas. And so there's a lot of different ways that these medications both can interact with what we expect to be relevant for psychiatric symptoms, but also for weight gain and insulin resistance. Looking at a couple of the initial studies, you can see here notable improvement with the SEP36386 on PANSS total scores. So effective potentially as an antipsychotic. And that there are a few, there have been a few, but relatively well-tolerated side effects, somnolence being maybe the most frequently observed, but everything else pretty minimal and pretty easily managed. Now, you may have heard that on June 1st, there was a medication that became FDA approved for the treatment of antipsychotic-induced weight gain. And that medication is the olanzapine-samidorphan combination. So we'll spend a minute talking about that. This medication has been in development now for several years. It includes samidorphan, which is an opioid antagonist. Similar, but notably different than naltrexone. It does work with mu kappa and delta opioid receptors to help with balancing things, not just as far as lowering cravings for eating, but may have other direct effects on the metabolics as well. So here's looking at waist circumference. You can see that the blue line, the olanzapine samidorphan, had notably lower waist circumference. This separated as early as week 1. In other studies, we have seen that it takes about 6 weeks before the olanzapine samidorphan group plateaus while the olanzapine group continues to gain weight. It is also worth noting that while there has been notable benefit for plateauing the weight gain with the olanzapine samidorphan combination, it still remains to be seen about other metabolic parameters. So these lines that are clustered below, you can see there isn't much difference between the olanzapine group and the olanzapine samidorphan group, with triglycerides up here really also increasing similarly. And again, as I mentioned earlier, triglycerides often being a harbinger for insulin resistance does leave something to be making sure you're paying attention to once you are able to prescribe this medication. Here's just a list of all the various adverse events, and you can see it's still, that many people are having some side effects, but that the weight increase is notably different in the people who are on the combination pill versus the straight olanzapine. Key learning points. So there are several medications that are in the pipeline for antipsychotic-induced weight gain and metabolic conditions. That's important because, as Carmen mentioned, these are often contributing to limitations in people wanting to take their medications and disrupting adherence, but also it overall helps the health of our patients. Importantly, the olanzapine samidorphan combination was approved by the FDA and is expected to be released in the market by the end of this year. Overall, we've talked about the clinical importance of making sure that people can tolerate their medication. Many of these folks who are starting medication and at this most pivotal period are young people. It's important, they want to look their best. It also helps to improve in the shared decision making. If you're asking people about the symptoms and the side effects that are most important to them, they're more likely to feel engaged in their treatment and actually want to stick with treatment and be open and honest if in fact they're stopping medication. And that gives an opening to at least have a conversation about it. It also helps notably with quality of life. People have increased confidence. And as Carmen talked about earlier, the lifespan is notably shortened in people with schizophrenia, and cardiometabolic disease is a huge factor in that. Now, as we've all been doing telehealth over the last year, it does pose a challenge. It is a little more difficult to get waist circumference and to get weight and blood pressure like we might otherwise get. So you need to do things to make sure you're really asking about it. Maybe have people try to encourage them to take their weight at home, things like that. Okay, so now we're going to catch back up with Jeremy.
I'm just so glad that we found a doctor who listens. My son was gaining weight, staying in and not seeing friends, and his grades were getting progressively worse. So we were really, really worried about him. The doctor asked him to talk about goals. Imagine that. And he said that he couldn't take a medication that made him too drowsy, and he was worried about the weight gain. Turns out he'd stopped taking his meds without telling us because he didn't like it. And now that he's on a medication that works better for him, I really feel like I can see my son coming back out. I mean, we've had conversations now that we never had before. We really talk. And he's even making plans to see friends again. And he's taking classes.
It has been hard. But I feel like I'm finally on a path. My doctor told me that he was optimistic for me, and that felt really good. Now, I just want to keep trying to show everyone that I can really work towards my recovery.
Okay, good to hear that Jeremy is doing better. All right, some questions to be thinking about. What is it that as psychiatrists we're not really thinking about, or what should we be considering that we aren't otherwise considering? I don't always have a great answer for this, but I think it's important for us to always be thinking about and looking through the literature to think about what might be some other strategies. Is it things like intermittent fasting? How can we manage to use exercise more efficiently? Are there weight loss agents that are in the pipeline that maybe aren't specifically targeted for antipsychotic weight gain? I think in general, it behooves us as psychiatrists and other mental health professionals to be thinking broadly about how we can help our patients.
Thank you, Dr. Balin. I agree. For summary and conclusions, we need to address more than just the symptoms of schizophrenia. We need to pick from medications that are currently available today with much enthusiasm about those that are coming down the pipeline that don't lead to an increase of negative metabolic symptoms to cause metabolic syndrome. That will help with adherence for our patients. So think about that when you're reaching for your medications. Dr. Balin?
So some conclusions. There are a number of medications in the pipeline. Most along right now are miricorilant, SEP-363-856 in particular. Also notable, the olanzapine semidorphan combination, now approved by the FDA as of June 1st, expected to be available by the end of the year. Make sure, though, you're talking about exercise at every visit. I can't emphasize that enough. It's a core part of my note writing template. I make sure to talk about it at every visit with patients. And remember, treatment is more than just the elimination of symptoms. Thinking about recovery is important. Considering a person's overall physical health is important in helping to make sure that they're achieving their best mental health. So think about talking about health throughout the time that you're working with patients. And with that, I'd be happy to take your questions.
Welcome back. Before we jump into question and answer, please be sure to answer the post-activity questions to the right side of your screen. Please click the submit button after the last question to successfully submit your answers. And as always, thank you for answering the polling questions. Thank you so much for the presentation. What an excellent job you guys did. Our audience has some really great questions for you as well, so let's get right to them. So what medications used today that are more effective, that are more metabolically friendly? Which medications are best when dealing with metabolics?
I can take that one.
Sure.
There's a STEP BD trial that is out there that will also showcase this, but your more metabolic friendly medications, and again, it doesn't mean that not one med doesn't make you gain weight, but in general, the more metabolic ones tend to be, can I name brand names? Latuda, okay, Vraylar, Caplyta. Those are your more metabolic friendly medications on the market today. Dr. Balin, anything else that you would add to that?
Yeah, I'd say one kind of rule of thumb that I tend to use is that the medications that are less sedating tend to also be the ones that are less risky for weight gain. So yeah, again, looking at the partial agonists, aripiprazole, brexpiprazole, and cariprazine being really good choices, as well as lurasidone also being really a good option.
Yeah, I can tell you clinically it's the same way. In my clinical practice, we have I treat a lot of models, and anything that makes them tired or sedated obviously plays a big role in their ability to gain weight. So we really try to stay away from the more sedating drugs. Absolutely. How quickly can clients see relief of symptoms on these low metabolic side effects medications?
Jump in here. I mean, I think this is going to vary between individuals. Some folks, many of my patients are going to do really well on the low metabolic risk medications. And as Carmen talked about before, adherence is often linked to people who feel like they're getting a drug where they feel like it's not affecting them negatively. And so you might think that a person is taking one of the, let's say, higher potency or, more quote unquote effective medications, like olanzapine, but if they're not actually taking it, it doesn't really matter how effective it might be in a study. So people are more likely, I think, often to take these ones, like the one we were just talking about.
Well, and I would also add, what is effective? Is it that they're feeling sedation, so they equate that with efficacy? Really look at the package insert of the med, or go to the nameofthemed.com and look it up so that you can learn what the onset of action is, what is the half-life, so you know when it should be at steady state, to help your patients to understand when is this med likely to work. If they're on a 1-week half-life medication, it's going to take a little bit. If they're on a medication that has less than a 24-hour half-life, you're going to get to steady state a lot quicker.
Carmen, going on that question, why does the half-life of medication matter?
Great question. So remember, it takes 4 to 5, depends on the book that you read, so 4 to 5 half-lives to reach steady state. Steady state is where you're really going to see that med kicking in and doing what it's supposed to do, kind of like the results that you saw in the clinical trial when they were at steady state.
Mm-hmm. And let's talk a little bit about lifestyle modifications. What kind of lifestyle modifications can we do, like exercise and stuff like that? What kind of things can we talk to our patients? Because a lot of times we'll have patients that talk about lifestyle changes and they're like, I hate doing that. They complain all the time about, hey, I need you to walk to the corner, and they just have a lot of difficulty doing that, and that they refuse to make any of these changes. And even though I prescribe them on my prescriptions, what kind of stuff can we do to kind of help bring this out and kind of educate them on doing these things? Jacob?
Well, I'll say I take advantage of the fact that I live in California. So that's one thing, which is my patients are outside a little bit more. So when I used to live in New York in the wintertime, it was a little bit more difficult. But I talk about exercise at every visit. It's in my note template. I make sure that it's something that we're always talking about. It's as important as understanding about people being social. These are the things that really matter as far as kind of overall experience. So patients know we're going to talk about exercise. It's like when they go to the primary care doctor. You wouldn't go to your primary care doctor and not expect to be talking about your fitness. So the same thing should be true here. We've also found in some of our work that helping patients to exercise together can sometimes be helpful. That you shouldn't sell your patients short. They're interested in social beings as well, even those who sometimes struggle with that. And so we've been part of some studies where we've been doing group exercise, and the peer pressure helps. It's just as the same as it might help for anybody else. The more you get people checking in on each other and keeping tabs on each other, the more likely they're going to want to stick with it. And we found a lot of success in doing that. And so as we try to bring in more social programming, one of the things is to also help people to exercise together.
I would add to it, they might not all be models like Dr. Malnick is having, but after COVID, a lot of us, including myself, have been sitting around more. So exercise doesn't have to be what a lot of people envision, like at the gym pumping iron. It could be moving, just going for a walk. It'd be even better if it was uphill a little bit to add in some extra cardio. Or things like, what are you drinking? Are you drinking full leaded soda? Can you drop it a little bit? Maybe a quarter of it be diet? What can you do? What's your sugar intake? What else is leading to the extra caloric count or carbohydrate count?
I can tell you that working in my forensic unit, we've done exactly that. We've used a little bit of the peer pressure world in which we've, had them all work together. But we talk about little short goals, starting off by walking to the end of the block, and then, going maybe halfway around the block, and then going all the way around the block. These kind of things really play a big role in helping our patients lose some of that weight. Also, we've learned that dry mouth, we did a study that showed that medications that dry the mouth tend to have higher increase of weight, mostly because they end up having carb cravings. And so we've been able to do that, and cutting back on sodas and juices has really been great for that as well. Another question, what do you do if patients gain weight on these low-risk antipsychotics?
Yeah, that's a tough one. I get asked that question a lot. There are going to be some people who are going to gain weight on any medication. So it's one of the reasons why I'm so optimistic and hopeful that there's a pipeline of new medicines coming down the line that may help with that. Like I talked about with miricorilant, and with maybe even some of these GLP-1 agonists that are out there. But when you have somebody in your office and they've gained weight and they're exercising, they say, "Doc, I'm eating salad, at every meal, I'm doing all the things you're telling me," it can be very frustrating. Sometimes it is as simple as changing to a different of the low-risk medicines, but sometimes it's not. And so that's where it's, really trying to work hard with them to dig in. Maybe it means getting, an additional nutrition consult, because it's possible that, maybe they're not aware of the snacks and things that they're putting in that are adding to their weight burden. It's hard to say, but it does mean that you have to really be careful. Also to have some empathy, right? That it's hard to lose weight. We know it's hard for folks to lose weight, irrespective of all the other challenges. And so that's another part of it. And then the last thing is, I always want to make sure that people really are socially engaged. That sometimes it really is that they're doing 30 minutes of exercise, but they're not really engaged otherwise with people. And so, especially now as we're starting to come out of our, COVID, lockdowns, getting people to be more socially engaged with others is another way to at least help increase the amount of energy expenditure for the day.
Absolutely. Carmen, anything to add?
I think he nailed it.
Yeah, he did. He did such a great job with that. I can tell you that it's so important to kind of keep in mind these things because it's calorie intake versus calorie outtake. The problem we run into is some of these medications kind of swerve everything over into a higher percentage of things being stored in as fat. And I think this is where some of those GLP-1 agonists have really helped. But before we get into that, you mentioned some of the new medications. And one of the questions that was asked is whether or not lumiperidone would be used as a first-line agent. And do you think that this is a good option for some of these patients that have a higher risk of gaining weight?
Yeah, so lumateperone, had the misfortune of coming out right at the beginning of the pandemic. So it kind of flew under the radar for a lot of folks. I think it's a drug we're all going to start using a bit more of. I'm optimistic about it. I've been using it in a lot of my patients for whom I might otherwise want to switch to clozapine as a sort of a step before that, perhaps, because as much as I like clozapine symptomatically, I am concerned about the massive amount of weight gain that people do often gain there. So I think lumateperone is a good option. I mean, I like that figure that I put in there about how people who switched to lumateperone for 6 weeks had either a decrease or at least a flattening of many of the metabolic parameters. And you can see that when they switched back to the previous med, it went right back up again. That gives me some hope that this is something that's going to be, again, more weight neutral. And I like it either as standalone medicine, as a first line, or, often because of insurance, it might be a second line agent. But also I do like it as an additional medicine, sometimes to use lumateperone as a second medicine when you need a combination. Carmen?
I fully agree. I think, if anything, there needs to be a paradigm shift for anyone in the realm of psychiatry, be it an NP or an MD, that we're going to have to fill out some paper. I mean, heck, if I went and got a new cell phone, I had to fill out paper. So if you need a new med, a better choice one to pick from, you're going to need to fill out a PA. I think it's more that we need to just realize this is how it is and this is what's going to need to be done. Because what if that was you? What if that was your family member or your friend? Wouldn't you want providers to first pick from the medications that are more metabolic friendly? I totally understand. Many patients, by the time they get to us, have already been on multiple options. Then fill out the paper, utilize historically what they've been on. We know from old studies, even the KD trial, the more we run from med to med, the less chance of efficacy. So let's really be mindful in our approach instead of, well, this is just what I learned in school, or this is what we do here. Let's use evidence-based practice.
Yeah, unfortunately, it's something that we deal with quite a bit, which is the insurance companies dictate in which direction we have to go to. Oftentimes, some of especially with younger patients, early into the disease states patients, they would respond better to some of these medications that have better metabolic profiles, but yet we have to wait for them at the end of our treatment regimen, mostly because of the fact that we have poor access to them. And, this is kind of leads up to the next question is, some of these new GLP-1 agonists, they've been using them quite a bit for weight loss. And actually, one of them just recently got approved specifically for weight loss. And I think that in psychiatry, we're going to be using them a lot more. I'm curious to hear what your opinions are in using these medications.
Yeah, I'm getting really excited to try them. I have not yet prescribed one yet, but I've been starting to work with some of the endocrinologists here at Stanford to talk about how we might be thinking about those. I think, to me, the biggest jump as well is that now they're not only subcutaneous, right? So for a long time, they were only available subcutaneously. And the idea of having to take either a weekly injection or a more frequent injection didn't always sit well, didn't quite cross that line of this is something people will be willing to do. But to be able to take it orally, I think opens it up tremendously. And so I'm optimistic. These have been drugs we've been looking at for a long time. It's very clear that they are metabolically friendly, especially when it comes to weight loss. Obviously, they're going to be helpful as far as maintaining blood sugar. And so I think that these may be opening up a whole new area of treatment.
Yeah, anything to add, Carmen?
I'm very excited. I have not even heard the lowdown on all of these meds either that are coming in the pipeline. So it just takes some time to get there. I'm in an outpatient setting, so it will take some time. Excited to learn about them and offering for our patients.
Yeah, I've actually had quite a bit of experience with it. And the new higher dose injectable has been really interesting because we've been able to get really great results with even the 0.5 and 1 milligram dosings. The higher dosing, I'm sure, will help even more. It's just going to be interesting to see how, as psychiatrists, we're going to be, or practitioners are going to be able to, in the mental health side, we're going to be able to use these pretty easily. It's hard to get insurance companies to cover them without that. And another question here on one of the newer drugs that you talked about is the olanzapine-samidorphan combination. One of the problems that some of the people that we've thought about, and some of the thought leaders have thought about, have been using them with things like Suboxone and buprenorphine, and just having a question. So I guess the question is it contraindicated in patients that are using the combination of buprenorphine or Suboxone or something like that?
I guess there would be certainly some interaction there. Probably would be hard. That's not something that I've actually encountered much. I don't treat a whole lot of people actually in my pocket on with opiate addiction. Actually, surprisingly, Carmen, I don't know if you have some experience there.
I do treat with opioid medications, but I've not used that new med yet. That would be something that I would do a medical science liaison inquiry. So if you do have the luxury of having a rep there, ask that off-label question and have them trigger their MSL, because I'm sure that there's data on that.
Yeah.
I mean,
samidorphan. Sorry,
with
samidorphan being
I'm sorry, I'm talking over each other. But the mu antagonism of samidorphan certainly would interfere with the Suboxone. So it certainly would be something you'd want to be really mindful of.
Yeah, and that's what I was going to say, is that it is a blocker of the mu receptor, and by doing so you don't want to cause withdrawal, right? So that is definitely, and I agree, having them fill out a medical information request form or a MRF, I think is absolutely what should happen. So yeah, great. What if clients are finally stable in terms of mood symptoms, but metabolics are concerning, and you're worried to switch meds? What do you do with those patients? Like, let's say they got the right med on, they're finally working. What do you do? Do you switch them? What kind of thing? Carmen, do you have any ideas of what you would do with these patients?
It's so hard because that's the risk-benefit analysis that we all face all the time. I would look first, what are the wins? Is it more social? Economics, are they finally able to work? Is it truly the med? Was it a change in lifestyle? Was it COVID that hit? Are they changing what they're eating? What else is happening? If they're finally stable, it makes it sound like they've been on a lot of meds. Man, that'd be a really hard one to switch off of, in my opinion.
Jacob, anything to follow up on?
Well, I think this is where shared decision making is so important, right? And if you started from the beginning with, we're all working on this together, we're figuring out what are our goals. Like, the medication is in service of a goal. If the medication is hitting one goal and not another, which is the one that's more important? And I can't make that decision for somebody, but I can offer my expertise. I can tell them, you're on this medicine and you're like Carmen just said, you're hitting all the targets. This one isn't there. Is there something we can do to help with the metabolics and keep this good drug, or is it that we need to actually make a change? And the patient's going to be able to drive that if they've already been empowered to give their opinions.
Yeah, I agree with that. It's so important to keep them stable. We know that these things are so vital for our patients, not only just today, but long term, right? We want to make sure that they stay stable. And there's always a saying, if it ain't broke, let's not fix it. And if it's something that we can fix, maybe if it's weight gain, maybe give them something to help them lose weight, or, if their blood pressures drop too much, maybe we can help them with that as well. Try to find ways to deal with their cholesterol. If we're getting the efficacy that we're looking for, switching it is one of those risk versus benefits, but we need to really do now with new medications to do it. Well, unfortunately, we're now out of time. Thank you so much for joining us. To see what sessions are coming up next, visit the live agenda page at the website. Thank you so much for attending the session. I hope you enjoyed the rest of the conference, and goodbye.